this is me way oversimplifying some of that, but that kind of situation where the health system is under pressure is at least partially manufactured. Like, money is a made-up concept in a way, right? And how much money we have to spend on health is a government decision. But
it's much more about priorities, isn't it? It's like we've got, billions for these things. How do we prioritize those billions? Does it go to the military? Does it go to double the military budget, or does it go to double the healthcare budget? That's a decision. It's not necessarily a lack of dollars, right?
And so it's also a decision to prioritize living within our means rather over investing in health, even if that means getting in debt. So there's a whole lot of manufactured things in there.
Hello and welcome to The Frontline with Gary Payenda. We've got a great guest for you today, Gabrielle Baker, Māori health policy consultant and expert who's written extensively in New Zealand Doctor and The Spinoff and dozens of other places about issues of Māori health inequity, the politics around race and health in New Zealand, funding decisions, and all the political chicanery that's been going on lately over healthcare. So Gabrielle, we'll get you on here. Let's say hello to you. Hi, Gabrielle. How's it going?
Gary. It's going well, thank you.
Kia ora. Can you give us a little background? You used to be a policy analyst. You've done lots of things around the health space. Can you give us an idea of sort of what your background is and how you came to it?
Sure. Well, I guess even as a child, I was a bit of a nerd, and my dream was always to be involved in government policy and making government policy better. And that's what I studied for, and that's what I did for around 15 years. And after about that amount of time, I started to get incredibly frustrated that there was this policy work and advice going on that was really good. It was people praised it. They said it looked good. They said it was saying all the right things, but nothing was happening with that work. It was going on shelves and it was being printed out in lovely, glossy booklets, but it wasn't changing anything within the health system. And I had to take pause and think, how can I as an individual have more impact on making the health and disability system or systems better for Māori, more effective for Māori? So for the past 8 or so years, I've been working independently as a policy consultant, but in any way that I can to strengthen the health system and make it more robust and I guess improve Māori health outcomes at a system level.
And you fuck up back to Northland, where I've lived and worked for almost 20 years now. You're Ngāpuhi, right?
Yes, Ngāpuhi, Ngāti Wairupi, Ngāti Kuriaho. So from the far north.
And where do you live now? Are you up here in Northland with me?
I wish. I live and I work in Whanganui-a-Tara, Wellington.
Yeah, okay. All right, needs must, huh? Yeah. Can you tell us, lay the background for this piece of work that I think you had a very significant hand in? This was Māori Health Te Tiriti o Waitangi and the impacts of outsourcing. So what is outsourcing and what does this report tell us?
So outsourcing, and then the way I'm talking about it in this report, is where the government pays private providers to deliver things that we have all come to assume would be delivered in the public system or would be publicly funded. And in particular here, I'm talking about surgical interventions. So
this is like Simeon Brown's 10,579 surgeries that could have been done in the public setting, but which are being done in the private
Yeah.
instead. That he loves this idea. So
Yes.
outsourcing is like
Yeah.
his go-to
Yeah.
answer for everything. Privatize, privatize, privatize. All right. And so you did a study on this, or a report on this, for the Association of Salaried Medical Specialists. So I'm one of those people. I'm a public hospital specialist doctor. And so this is my union, and they've sponsored you to take a look at this work, right?
Yeah. That's right.
Okay.
So so it is looking at elective boost. That's the Simeon Brown TM branded sorry. That's the Simeon Brown brand of outsourcing. But outsourcing has been happening for, across multiple governments. This one has a different flavor though, because it positions outsourcing as a long-term solution, not a temporary capacity increase, if you like.
Yeah,
So,
they're talking about 10-year contracts, which I've written some stuff on Substack about that, because it just blows my mind that the public hospitals, our departments, have absolutely no 10-year guarantees. We don't have a 10-year time horizon of how many consultants we'll have, or a 10-year promise that we'll have this or that money, or this or that hospital department enlarged. We barely can even plan our hospital redevelopments. I think the second stage of our hospital rebuild is not even funded yet. They haven't like allocated and squared away the money for it, even though they've announced it for years. So it blows my mind that they want to promise the private sector, so private equity companies, private corporations, private hospitals, a 10-year, essentially an income guarantee off the back of the tax-paying public, because Simeon and others have said that they need that kind of a guarantee. Like, they need the security that comes with that. And I just find that laughable, because don't the patients need that security as well? So that's one of the things you looked at, eh?
yeah, so I looked at, the kind of genesis of this paper is that there has been so little true investment in Māori health in the last few years. And what we're trying, when I say the last few years, I probably mean since the disestablishment of Te Aka Whai Ora. So, we're kind of in this position of where do we pivot to try to increase Māori outcomes? Where is the place that we go to? And I was starting to think about, when the health system is under pressure, and that is a line we get fed all the time. And some of the other ASMS commissioned a range of papers, and this is me way oversimplifying some of that, but that kind of situation where the health system is under pressure is at least partially manufactured. Like, money is a made-up concept in a way, right? And how much money we have to spend on health is a government decision. But
it's much more about priorities, isn't it? It's like, we've got, billions for these things. How do we prioritize those billions? Does it go to the military? Does it go to double the military budget, or does it go to double the healthcare budget? That's a decision. It's not necessarily a lack of dollars, right?
And so it's also a decision to prioritize living within our means, rather over investing in health, even if that means getting in debt. So there's a whole lot of manufactured things in there. But even if you accept all of that, when a minister is told the health system is under pressure, they have a limited range of tools available to them. They could themselves invest in long-term capability and capacity for the health sector, like a 10-year investment plan in hospitals. They could try to put pressure on creating efficiencies, using workforces differently. But there's a finite range, all of which take time. So health ministers often look to outsourcing for that short-term boost, but I don't think, and that's what the paper looks at, I don't think that's been considered from how does this meet or demonstrate the government's commitment to Te Tiriti or Waitangi? How does this align with the obligations set out in the treaty? So that's what started my thinking on this paper. And the paper's in kind of 3 parts. The first part looks at, well, what are the treaty obligations in the health sector? And it takes as a basis the kind of thinking that's in Mātiki Mai, that says Te Tiriti has creates for us an arrangement where there is a kawanatanga domain, that's what the government operates in. There's a rangatiratanga domain, that's where Māori control over Māori things. And there's a meeting in the middle of these domains. And so I'm not looking at the rangatiratanga domain, I'm looking at what the kawanatanga, what the Crown is doing around Māori health and Te Tiriti. And Te Tiriti has been part of the kawanatanga health system since at least the 1970s and 1980s, when Te Tiriti starts to be acknowledged as the foundation of good health, where the advisory committees to the ministers of health are saying Te Tiriti is an essential part of what we do within health. So one of the reasons for looking at that was to emphasise lots of the discourse that we have at the moment that talks about, that kind of positions Te Tiriti as being divisive, that positions a focus on Māori as being divisive. It ignores that this is something that has grown in our country over 50 years, this idea of Te Tiriti and health. So that's what the first part looks at. The second part looks at outsourcing and privatisation. And outsourcing is one step in a continuum of privatisation. And in New Zealand, we've shown a range of those steps. So one of the first steps is corporatisation, and that's where you start, running hospitals like they're businesses. You start to do things like split the purchaser and provider, which is something we did at various points, but was very strong flavour of the 1990s in New Zealand's health system. You've got Crown Health Enterprises in the 1990s as well, and some of the research on that says that at the time, New Zealand doctors, specialists, felt like they weren't able to make the right decisions for their patients because it became about this kind of commercial bottom line, managers making decisions on health. So, so corporatization.
I mean, they purposely made sure doctors would not have control over a dollar of the spend. So if you say, we need this staff, we need this person, we need this resource, it is guaranteed that your head of department, your clinical director, all the way up the hierarchy, will not be able to spend a dollar to ensure that happens. It will have to go to a series of bureaucratic managers and non-clinicians to get sign off and approval. And they viewed that as a good thing. But of course, it creates layers of distance between what actually needs to get done. It also creates an inefficiency when you've got an extra middle person in there. That's not what's best for the patient, obviously.
And there's definitely some writing about the 90s, which indicates concerns about quality of care and outcomes for patients. Outsourcing is also on that same continuum as public-private partnerships. So this idea that private investment might be able to support public services, and as part of that private investors can profit off of public services. And
that gets us into a really dangerous zone. When you start saying this essential public service for the public good, this social good, can be used by a corporation that wants to maximize profits, like that's where you get into all kinds of problems. And then you get into the sort of David Seymour and Act, let's deregulate this. Let's get the shackles off of business. And really, let's just go all out for greed. And it's one thing when you're selling widgets, but when that is someone getting cancer treatment, it's a whole different kettle of fish, and it's very bleak, and it's horrible as a clinician to be trapped in the middle of all of that.
I can imagine. But public-private partnerships, they're usually used for big infrastructure projects like roading. But there's increasingly signs that I'm interpreting of this moving more into kind of health and social services. And co-investment is a stream of the government's social investment model. So to me, co-investment and public-private partnerships are, they look very similar on paper. And then there's full-on asset transfer, where something that was publicly owned and publicly run goes into private ownership, or in the case of New Zealand state-owned enterprises, shares are sold in that previously public entity. So I think it was important for me to spell that out, because people talk about privatization as the same thing as outsourcing. And yes, outsourcing is part of privatization, but privatization actually has a range of different ways that it can get into the health system. And we've seen a lot of those already. So
can we have a chat about this New South Wales thing? New South Wales banning acute hospitals from public-private partnerships. So in the rest of the world, there are many sort of famous anecdotes and cases where this turned out disastrously badly, right? Putting rampant greed into a hospital is not a recipe for a good outcome. We know that private healthcare is very expensive. It has that extra middleman that's sucking out profits that often don't stay within the nation. And we know it actually gives worse care with worse protections for employees and all of the rest. I mean, it's basically exploitation for profit. And, could it be done with really rigorous safeguards and fantastic regulatory standards to guarantee things? Well, perhaps. That's never what we end up with, right? This is always a race to the bottom. It's a race to maximize profits. And so there was a very famous case. A little boy died in this public-private partnership hospital project in New South Wales. And then their premier eventually came out and said, never again. New South Wales will never do a public-private partnership where the private sector gets to manage a public hospital, essentially, a public good, because it's just too dangerous. And so the news that just came out was that the government will have to now spend $190 million to buy back this disaster of a public-private partnership hospital. So they're never going to do it again. Good on them. At the same time that New Zealand is like running headlong towards this. Right, we've got a little hospital in town here. Small thing, needed to be rebuilt 30 years ago, but it's just beginning to get rebuilt now. Although the project has been broken into small mini projects and spread out over many years, which is it's like a delay and defer tactic. But now they say that the part of the hospital build that actually holds all the patients, the medical and surgical wards, the phase 2, doesn't have any money allocated to it. And yet it's all nominally, theoretically, supposed to be done by like 2031 or 2032. And so a lot of us are saying, like, are you just setting us up for a New South Wales public-private partnership here? Because that's really another thing that is beloved by the current government coalition politicians, is this idea that the public sector is going to leap in with money and save us. But of course, what history shows in the rest of the world is that they're going to saddle our children and grandchildren under the yoke of debt that they will never get out of. And then ultimately it falls down, and like New South Wales is going to be $190 million in the hole. So is that kind of a potential model of a path we could be going down?
I think, the thing that I've looked at mostly is this outsourcing within it. But I think that the example you've given is the concern that you see in literature too, that that things like outsourcing are the thin edge of a wedge that then opens more space for the more extreme ends of privatization, which potentially that kind of public-private partnership is, and selling off assets to a private sector to run those assets in health. I looked at, even though it wasn't the primary focus of my exploratory report, I looked at the evidence around outsourcing and its effectiveness as well. So the advice from the Minister of Health from Health New Zealand earlier this year, or at the very end of last year, I can't quite remember which one it was, said that outsourcing could be achieved at an acceptable price and that it would support wait lists in the short term. But they also said it takes time to stand up. They're not efficient. They put pressure on the workforce because they put pressure on workforce availability because Health New Zealand and private hospitals are competing for the same workforce. So it doesn't magic up more people to do the job. It just creates more competition between two employers. And then looking at the evidence, right? So there can be improvements in outcomes for people using through outsourcing. So I looked particularly at evidence from England. So there can be improvements, right? And there can be some sense of good quality, but it's really hard to tell because of the data they collect. And when you looked at those kind of positive patient experiences, those were more dependent on the doctor themselves than the setting. So the same doctor operating in public and operating in private got the same level of patient satisfaction. So some of that stuff is a bit manufactured not manufactured. You have to question any of the outcome data because there are some confounders in there, right? The quality question is also complicated because private hospitals tend to be given lower risk and accept lower risk surgery than public hospitals. So it's skewed. You're not comparing apples with apples. And there was also concern in the literature that when things go wrong in private, it becomes a public issue because these private hospitals don't have ICUs, right? So the public hospital ends up taking on the poor outcome.
I love how you've researched this and found the literature and the stories and things.
I'm sure that.
But I mean, I get to see that every day, right?
Yeah.
Like I work in an emergency department, and when something goes bad in private throughout the country, not just this hospital, those patients are on the first ambulance out of there.
Yeah.
Because that private hospital, part of their model is to not take complex things. They want to maximize profits. They want a quick cataract surgery that could take 20 minutes, flick it out, done, next one in, the person's healthy, they recover in 2 hours or whatever, they go home.
They walk away.
Do not want an elderly, diabetic, hypertensive person with complicated problems and the risk of infection and all of it. That all the hard and bad stuff and unprofitable stuff will remain in the public sector, bogging it down and making it even harder to get through lists. Whereas it's cream skimming, I think is a nice Kiwi term for it. It's basically just cherry picking the most profitable, most beautifully profitable cases and leaving the rest for someone else. And of course we see it every day, right? There's a list. If you're in an ED, there'll be a list in any ED in New Zealand about what things you can refer privately, when ACC might pay for it or what have you, and then what things that remain within the system. And of course, within the system, there can be long delays to get seen. And the stuff that is gladly accepted in private has an unsurprising tendency to be highly profitable, right? So scoping an athlete's knees, like looking at their ACL tear, that's great. Talk about a knee infection in an elderly, in a pensioner. Oh, no. That does not go to private.
Not gonna happen.
Right?
Yeah.
And of course, Simeon will say, like, this is a solution. We're getting the waiting lists down. But the solution requires a public surgeon, public anesthetist, public nurse to leave the public sector and go out in the community and work in private at the private hospital, meaning that we're hollowing out the public hospital to help the private hospital. That just sounds so crazy to me.
And you're right. I'm not a clinician, and so I'm quite reliant on what people say to me, but also what I can find in literature to back that up. And what you're saying is there, as is so the idea that the private hospital waiting lists can also drive the public waiting list, because a lot of the surgeries that aren't getting done in private in public. Sorry, so some of the surgeries that aren't being done in private and public are not being done because of ICU capacity, which is a decision that private hospitals don't have to make because they have no ICU. And then the ICU gets overloaded, which then further elongates the rest of the waiting list. So it's
Sure.
and the
like
other vicious circle. And the other thing that kind of you touched on it is that there's no evidence that this is good for inequities, and in fact the evidence tends to suggest it increases inequities. So that's the unfair and unjust differences between different population groups. Because you're usually talking about lower complexity surgeries, it tend to be the wealthier, younger, whiter populations. So that's who's most likely to benefit. And private hospitals are most likely to be in more affluent regions. I mean, Northland has not got many private hospitals across its poorest areas, right? It's in specific areas. And in the NHS England, hip replacement data showed procedures had increased by 12% by using outsourcing. So 12% increase sounds kind of good. But the least deprived 10%, so that's the ones who are most well off, benefited 3 times more than the poorest people. So it's it's not just not helping inequities, it's exacerbating them.
And I talk to a lot of patients who, and even some staff who are torn because they obviously appreciate the fact that they might get their procedure done quicker. But they also understand that the next time they need something from the public hospital, it will be a hollowed out workforce and a hollowed out infrastructure that will be there for them. It's not accidental when you read about, on an almost fortnightly basis, that the new private hospital is opening up. A private hospital is doubling its theater capacity or its wards. Or like in our community, new mega radiology corporations, sometimes with international private equity funding, are moving into town because there is a tsunami of taxpayer money that's now going out into private. And that it's like blood in the water. Whenever you hear the word private equity has moved in to your telehealth, to your urgent care, to your GP practices, they're buying them up, and to your private hospital systems, you know the game is over for your public system because private equity is chasing ridiculous profits. That's what they're there for, and it's a one-way street. Of course, when you lose an ear, nose, and throat surgeon, I was just talking to one last night about this. When you lose his colleagues to the private sector, they're very unlikely to come back to public and want to work in a department that's even more understaffed than it currently is, and under-resourced and overwhelmed. And of course, all the teaching requirements remain in the public hospitals, right? Because privates don't want to waste their time or effort on that because it doesn't drive profits. The only place I've heard that it does drive profits is where they get reimbursement from government. So like in the US, the private hospitals learned that they could rake in something in excess of $80,000 a year if they took on trainees. And so they opened up the floodgates for creating residencies in these private hospitals that almost uniformly were worse than the ones in public hospitals. And of course, the Regs found very poor teaching, very poor case mix, exploitative practices, and not a good training milieu. And so, I mean, I hope that doesn't come here, but I fear it will.
And the literature sort of suggests something similar. I couldn't find much on job satisfaction, but I could see that reports of workforce having decreased training opportunities and a loss of professional identity. So
yeah,
and
also huge attempts to weaken and break the unions within those organizations, because these private hospitals, the last thing they want is an organized and united workforce. They want cheap labor that's easily fired. Yeah, so it's really a corrosive effect on the whole host of society, the whole rest of society.
Yeah.
And it begs the question of why we even need these middlemen. Like, why do we need to send my anesthetist out to private when they're telling us they could work extra lists in theater on the weekends if someone would just pay the nursing staff?
Yeah. So the thing that I in my report, so I didn't I didn't go into some of those arguments, but I did say, well, outsourcing has been a feature for a long time, and it's being amped up now. But I definitely would emphasize this is not new, right? Previous governments have also gone for outsourcing. But I think all of those decisions have been made without true te tiriti or waitangi engagement. So all of the stuff I've talked about kind of up till now on outsourcing, and you've talked about with me, that's true no matter what health system you're in. In our health system, we've got this specific requirement to honour te tiriti. And what I try to do is say, well, how are each of the principles of te tiriti as articulated by the Waitangi Tribunal being applied here? And where I landed was not very well. Like, either they're being ignored, like the concept of equity, or they're not being thought of at all, like the principle of options. So the principle of options is that Māori should have two key options, right? One is that Māori should be able to access services from Māori providers. And the other is that Māori should be able to access culturally safe care. And in the discussions on outsourcing, there's no discussion I could find evidence of. Doesn't mean it doesn't exist. It just means I could not find evidence of it. That Māori, there are discussions by government about how to include Māori in outsourcing as providers. So there's currently no Māori-owned surgical hospital. I mean, I've had to make that assessment myself because there's no ownership information provided with the list of surgical hospitals, but I'm fairly confident in that. And if you're investing in a 10-year outlook outside of public hospitals, then you should be thinking, how can we support over 10 years Māori building the capacity and capability to enter outsourced surgery, if that is indeed where the health system is going. So there's no discussion on that. And then there's no discussion, well, the decisions on outsourcing do not talk about cultural safety, do not talk about cultural competence. The health system is required to meet a bunch of surgical hospitals are required to meet Ngā Paerewa, which is the health and disability sector standard. But an evaluation of that a couple of years ago said that the health system really struggles with the stuff around cultural safety, partly because they don't know what it means, and partly because even the ministry's team doesn't know how to implement those requirements. So when I looked at all of the principles, that one really stands out to me as an area just neglected in the discussion on outsourcing, which to me undermines, or at least calls into question, the robustness of the decision making, right?
Gabrielle, can I just have a minute to give you my personal perspective on some of these issues you've just brought up, like the three or four?
Please.
You don't have to comment. I don't want you to have to say anything that you don't want to get into, like it professionally or whatnot. But let's just be realistic. There's just flat out racism here. Like, someone has to come out and say it. This government, ACT Party, David Seymour, they don't want to, as you said, there's a requirement to honor Te Tiriti. They have no intention of honoring Te Tiriti, regardless of what nice little words they might put on it. They're trying to kill Te Tiriti, to rip it out of the fabric of New Zealand culture. You've got an education minister who literally is ripping words like kia ora out of children's books because they're Maori and that te reo, and it's going to mess up kids' ability to learn. But of course, they're going to leave in cafe. They're going to leave in pizza, right? That's okay. Somehow, like that, those foreign words are they're New Zealand. But no, this isn't a let's call it what it is. This is an assault on Maori. It's an assault even on the concept that Maori were here first, that they are tangata whenua, that we have a thing called Te Tiriti. That's all this is. You look at the silly rubbish they do. Like they took the Paiora Healthy Futures Act and they like renamed it the Healthy Futures Paiora Act. Like this is a game. This is a series of dog whistles. It's an attempt to sort of rark up the right-wing extremist faction of voters who will come out with their Brian Tamaki marches and fight against any trace of Maori culture seeping into the social fabric, even though like 1 in 6 people in New Zealand whakapapa back to Maoridom. Like it just blows me away. Like in 18 years here, I had to do one, maybe two. I think there's 2 courses on Te Tiriti, and um, and I think when you come here from another country, you're first fascinated and maybe even dismayed or confused at why you're having to do this. And so that for the first day, you're like, huh, this is interesting. But over time, as you actually start to take care of Maori people, you realize there is a Maori culture. There are cultural differences, um, let alone the vast health differences that mean your Maori patient is likely to die 7 or 8 years earlier than your Pākehā patient, and for a whole host of reasons. First and foremost, which is poverty, followed closely by racism. And so you begin to see these things, and you realize those 2 courses I took on Te Tiriti or Tikanga Māori or whatever, they didn't hurt. They didn't kill me. It wasn't some horrific thing I had to go through. They were a blink of an eye in the 18 years I've been working, and they gave me an insight into how thousands and thousands of my patients view the world, view me, look at healthcare, their goals for end of life, the meaning and value in taking care of family. I mean, there are real significant differences that one needs to know about, um, and and yet in the media, and I'm going to say corporate-owned media because it's now owned by billionaires, right? Like the Herald is a billionaire's pet project. In the media, you only hear about the negatives, like, oh my God, I had to take this course. I can't believe it's a waste of time. It's only a waste of time if you've predetermined that it's a waste of time and you want it to be negative. It could also be a productive way of you learning about the world and treating your patients a little bit better. So that's my little soapbox thing, is that this is fucking racism, and someone needs to come out and say it. And then maybe we could move forward and like actually talk about how we fix some problems. But that's my 2 cents. You don't need to agree with it or comment, but yeah, I just have to say that.
Well, I think racism is at the core of a lot of the inequities that we see, and a lot of the experience, like Māori experience racism in a whole bunch of ways. One of them is the structure. So I guess what I'm calling out here is the structural ways in which Māori are excluded from decision making and not factored into what's important and what's not important. And there is also something about the way Te Tiriti becomes this political hot button. I think you talked about dog whistle, it's those kinds of things. And I, to some degree, well, I was hoping that this paper does. Like, I know there's finite things that a paper can do, but what I wanted to show was that it's not a radical idea to be thinking about te tiriti and health. That it was a radical idea 50 years ago. It's not a radical idea today. And even when I was going through stuff from the 1990s, which was this very neoliberal, I don't know if you were in the country at the time, Gary, it was a very neoliberal time for New Zealand. That's when we have the introduction of Crown Health Enterprises. It's when we have the idea that any provider can provide health services that are commissioned from the government, not just the public hospitals, right? So it's a neoliberal period, but they even still talk about te tiriti more than what I think is becoming acceptable now within the public service. So part of what I wanted to do was to say, this is not new stuff. This is 50 years of how health policy has evolved in Aotearoa. And even with that background, you're not learning from that. You're going ahead and making decisions without, to me, it's without robust policy analysis, without robust evidence-informed decision-making, none of that stuff. It's quite ideological, I guess.
In preparation for this talk, I looked at a few things that you've touched on. So inequities for Māori. The median wealth that Māori have is something like a quarter of the wealth that Pākehā have. Their property is sometimes tied up in communal land holdings that you can't mortgage, you can't build on, you can't build equity on. So you've got this unproductive asset that you're essentially moving further down the wealth chain as the rest of the country is moving up. So in so many ways, it's quite so well entrenched and systematized. It's almost guarantee that Māori are going to be a step behind at almost every juncture financially. We know medically they get less specialist care. They get fewer specialist referrals. The referrals are slower. They have less cardiac catheterization for their MIs. They have less colonoscopies and fewer surgical interventions for their cancers. They have almost a doubling of surgical complications and an increase in death post-operatively. And like, to add insult to injury, now they're saying, even though we know that bowel cancer, specifically, this stuff blows my mind. I've got a friend who's does colonoscopies. Bowel cancer kills Māori young, and it kills Māori younger than Pākehā. So 50% of bowel cancers in the less than 60-year-old group in Māori versus 30% for Pākehā. So it is absolutely killing Māori younger than Pākehā. And there was funding to get Māori patients colonoscopies starting at age 50 to help them not die, right? Because they die 7-8 years younger than Pākehā. In some places like far north, something like 15 years younger. And this government said, no, even though the funding is directed towards Māori at age 50, we're going to redirect it, the funding, and increase their age so they now get screened at 58, guaranteeing that more of them will not get picked up when they need to be picked up. And almost all colon cancers start from polyps, and almost all of those polyps could theoretically be caught early. It's often a slowish progression, and they can be removed and cancers prevented and people don't die. But we've guaranteed that 8 years worth of Māori, 50 to 58, will die, will get cancer and die. Some of them will die because of this rule change. And you had a Māori doctor, politician, who helped support that into law. That was Shane Retty's stint as health minister. Now we have Simeon Brown, so sort of one worse than the other. I don't know what whether you have a comment on that, but you just look at how very bad things are, and then you look and you realize that for all as bad as it was, politicians are actively making it worse, aggressively worse. What are your thoughts on that problem and how we deal with it?
Yeah, so that problem is structural racism, right? So a decision is made that will. The reason I say that is that this kind of issue has been canvassed in the Waitangi Tribunal, for example. It's definitely been the subject of lots of kind of opinion writing and that kind of thing. The idea that one size fits all is better than a targeted approach that actually makes an impact. So the idea that everyone from age 58 rather than Māori from 50, even though both things cost the same, and even though one of those is better for outcomes, one size fits all is more important than, like, an ideological decision that one size fits all is more important than what the evidence says. And the Waitangi Tribunal has talked about this in the context of active protection. So how they describe active protection is that the Crown government has to be well informed and has to take action to eliminate inequities. It can't just say, "Oh, we're doing the best we can for everybody." That's not meeting this requirement of active protection. And you talked about bowel cancer. You see it in lots of different areas. Sometimes you see it in things like screening age, which is this. Age-related stuff is really common as an example of institutional racism. One that came up in the Waitangi Tribunal under the disability area was related to stroke, where Māori have stroke younger than non-Māori. For non-Māori, it's an over 65 age-related issue. For Māori, it's not associated with being over 65, it's much younger. And the stroke support, rehabilitation support, was funded as part of aged care. And if you were under 65 and had a stroke, what the argument was that you weren't able to access care because it was designed for people over 65, and not just designed for it. You had to be over 65 to be eligible for it. So, the bowel cancer one is a really obvious example, and it was one that was fought hard under a Labour government who also had a discriminatory age range. But some wins were made, and now they're backtracking. And the backtracking feels really spiteful, eh?
Yeah, I don't have words to address it. I mean, they took ethnicity out of the funding formula. It used to be largely based on age and sex, deciding where Health New Zealand dollars come. Do they come to Northland in X quantity or not? And they wanted to improve that, so they looked at other factors, income and what have you. But again, the current government decided against all recommendations from SAPERE and other consultancies and professionals and public health doctors, and the literature, the medical literature, they decided to take ethnicity out of the calculation.
Yeah.
How do you describe that other than an attack on the ethnicities that are at the bottom of the league tables all the time, Māori and Pacific people? And we know that these health outcomes are not just based on income. It's not as easy to say, like, oh, it's just money, it's just wealth, it's just income, because some of these problems transcend income. You can be having a high income or a relatively higher income, and based on your ethnicity, in some of these cases, you will still be more likely to die and less likely to get chemo, et cetera, et cetera. So for them to take ethnicity out of it is condemning people to, ultimately, some people, a subset of people, to death and a bad outcome that they didn't deserve.
Yeah.
It's wild that we are living through this sort of neoliberal stuff. It's a watered down version of sort of Trumpism and the sort of far right extremist stuff that you might see in a Nigel Farage type setup. in the UK, but it's in the same vein. It is of the same flavor as that divisive and sort of racist way of operating a society. And it's super sad. I think a lot of people in healthcare are sensitized to it because we look at our patients and we say, we should just help people where we're able. This person needs the help. They should get the help, because we understand that ultimately leaving people suffering and in bad health doesn't help society. It doesn't help me be richer or safer in the world when people don't have dental care. It doesn't help New Zealand prosper. It doesn't help small businesses prosper when people are ill. And yet all the things we've talked about for 49 minutes now have centered on decisions made on purpose with intent that worsen health outcomes for New Zealanders and cost New Zealand more money ultimately. This stuff's expensive. By neglecting people, it's really expensive. The outcomes are bad. I see that every day. I admit them to hospital, and I know that that'll be thousands, if not tens of thousands of dollars for preventable problems.
I mean, we have been talking for 49 minutes, so I won't prompt too many more discussions, but there was two things you said that I just wanted to mention. One was that if you're a bit neutral on whether privatization is bad, and people are allowed to be, a counter is looking at what is happening for oral health. So oral health is largely a private service in Aotearoa, and outcomes for Māori are terrible. Access for Māori is terrible. That's what happens when there isn't a public system there, or the public system is only there for relief of pain and emergency dental issues only. The other thing I wanted to just, you mentioned funding and ethnicity data and that kind of thing. One of the other things that I think about is, and it's kind of related to what got me to leave the safety of being a public servant, although it's not super safe now, is that strategies are written, and they say all the stuff like the primary health care strategy said all the stuff about different models of care and how you would treat a patient and how you would wrap around that patient. And it was never implemented fully. The funding never really matched what was needed. And if the strategy was properly implemented, it would cost the government so much more than they paid. And the shortfall is being met by Māori whānau, it's being met by Māori providers. So when they don't invest, Māori providers are still going to be there providing care, whether or not they're being paid properly for it.
Right. And again, having had the privilege to work in Māori communities up here in Northland, you realize that this concept of shuffling your old family member off into aged care, assisted living, a residential, whatever, that's really alien to a lot of Māori communities, families, whānau cultures. Like it isn't a natural thing. You take care of your own, and yet you will never, I've never heard any right-wing politician acknowledge the immense amount of money that is being saved because Māori are taking care of their own family members, right? They're pulling together and they're looking after Nan, even when she's incontinent of urine and feces, even when she's got profound medical problems, even when, if she was Pākehā, she'd be statistically much more likely to be in a lockdown dementia unit with 24-hour supervision and cares and on-site nursing at a cost of $80,000, $90,000 a year. That's being all dealt with in the family, outside the realm of costing the public money. You'll never hear anything about how much money Māori cultural practices save the system. You'll only hear about it costing the system. Quite wild stuff. Thanks for your time. Is on a final note, and on a positive note, because as I told you before, this is the most depressing podcast on YouTube right now. can you give us like 2 or 3 things that need to happen? Let's say this government is listening and they decide this isn't how they want to conduct the last year of their reign. They want to do better, or the new government or a different government, whatever. If someone has some power, what are like 2 or 3 simple and very practical things that could be done to help the country financially, the country socially, and Māori in particular? What are like the 2 or 3 things that need to happen that are obvious?
I'm all about holistic, so I never really think there's 1 or 2 things. I think there needs to be major things. So I'm just going to preface it by saying what I think there needs to be is constitutional change. Te tiriti needs to be foundational in a way that in the way the government operates. So let's just put that to one side. My little thing, constitutional change. It's not that I think Te Aka Whai Ora should be re-established, this Māori Health Authority, but I think that its dissolution. So I was involved in some of the early thinking about that. I've worked with people and talked about it a lot in my last 5 or so years. But the way that it was set up was never the way it was intended when we were first talking about it. I think something more like what we first intended is needed, and that's an independent Māori health authority, independent of the Crown, but able to be involved in decision making in a way that increases transparency, increases robustness, increases the voice of Māori in decision making. So there's that thing, a kind of structural thing that's needed. And in the report that I did, I had a few recommendations that I would also stand by. So improved ethnicity data quality, better Māori data sovereignty, and investing in the capability and capacity of the health system. And that includes investing in Māori health workforce. So there you go. Those are my little things.
You know, you say independent Māori health authority. Wouldn't it be a dream if all our essential public services were ring-fenced and protected with an impenetrable steel fence from politicians, where the funding for healthcare was a certain percentage of the overall budget, and the politicians could not affect it, could not use it like a piggy bank. And so one government gets in and guts it and gives the money away, and the other underfunds it, et cetera, where the money would the funding would just be there. It would almost be like the 10-year plan we're talking about for private hospitals. They would be guaranteed a 10-year time horizon of unassailable funding that, regardless of who gets into power, it will be there. And then you could actually start to build and plan and build our hospitals, and with some assurance that you'd be doing the right thing. So an independent Māori health authority, an independent public services authority as well, that kept us safe from rapacious politicians. How nice would that be?
Well, I think that, and certainly I haven't thought about your suggestion, but the idea of there being a different way of thinking about how the government works is part of that constitutional change I think we need.
Yeah. Do you think we'll get there?
I have to hope we will get there. I think that's the answer.
Yeah. We're certainly well, I don't think we're headed in the right direction with what we're what we've been talking about for the past hour, but yeah, maybe there is some hope. Maybe there's some hope. All right, thank you so much, Gabrielle Baker, Māori health policy consultant, ASMS policy paper analyst and author. Let's put this up here one last time. You can find this online under the ASMS website, Māori Health Te Tiriti o Waitangi and the Impacts of Outsourcing, an exploratory report. Gabrielle Baker of Baker Consulting. thank you for your time, and we'll have you back someday to talk about the part 2 to this, like whatever the next step is in the coming year. Thank you for your work. I appreciate it. And thanks for
Kia
coming on
ora.
the front line. Kia ora.
Thanks for having me.
Anytime. All right, so that's it for another episode of The Frontline. Gabrielle Baker was great to have on today. Thought-provoking. Please share this with people so that we can continue this conversation in the homes and in the streets and in the workplaces, and so that we can actually change something for the better, because we cannot allow things to keep going in the direction that they are. All right, that's it for me, Gary Payenda. I'll see you next time.